Present when your name is called. Dr. LaDonna Thomas.
Present.
Dr. Amy Steele.
Present.
Dr. Raquel Ingram.
Present.
Dr. Anurado Rao Patel.
Present.
Miguel Pinheiro.
Present.
Dr. Sharona Johnson.
Present.
Thank you, Dr. Johnson. We have a quorum for this called meeting.
Thank you, Ms. LaFear. Committee members are reminded they are to abide by the State Ethics Act and the Code of Conduct to avoid both conflicts of interest and appearances of conflict. Any committee member should identify yourself and the conflict or the appearance of conflict and refrain from any undue participation in the particular matter. This meeting will be conducted in accordance with Robert Rules of Order. Voting will be conducted by roll call. Following discussion, I will call for a motion and a second prior to a roll call vote of the joint subcommittee members. When making a motion, the joint subcommittee members shall state their name for record-keeping purposes. An official vote on the motion before the committee will take place by roll call at the conclusion of the discussion. Are there any questions regarding the review of Robert's Rules of Order? The purpose of this emergency call meeting is to discuss the joint subcommittee's response to the declared state of emergency and the governor's executive order 318. At this time, I would invite Meredith Parrish, Chief Legal Officer of the Board of Nursing, to address the joint subcommittee. Meredith, proceed.
Thank you. Thank you, Dr. Johnson, and thank you, members of the committee, for being here today. I want to express my appreciation for you all, as well as Marcus Jemison. Marcus and I were able to speak this morning and talk about some of the concerns from the Board of Nursing standpoint that we've been hearing from nurse practitioners in the area, which is a large part of why this meeting was called. As you all are aware, under Executive Order 318, the governor has declared a state of emergency and ordered regulatory boards to waive or modify the legal or regulatory constraints in order to specifically allow persons to provide care if they're licensed in other states, but not licensed in North Carolina, and provide care if they're retired or inactive, if their license is inactive. Under Executive Order 318, we have to look at our MP rules and regulations, which we share for joint regulation. I've provided a draft copy as a starting point for discussion, which is the ask from the Board of Nursing today that the committee consider waiving the requirement of a supervising physician for the limited period of time through December 31st of this year for those nurse practitioners who wish to volunteer or practice in these affected counties only. So the ask is limited in time and territory to these specific regions. The first ask is to waive the supervision requirement for the nurse practitioners in that area, along with relaxing some of the restrictions for those who currently practice in that area and do have a supervising physician in that area. The relaxation of the restrictions is consistent to what the boards did during the time of COVID and relaxing the requirements, though it is a little more liberal in that it does waive the requirement of a supervising physician for those individuals who don't have one currently coming to this area to practice. The cohorts of individuals that these waivers seek to address are those out-of-state nurse practitioners or nurse practitioners in the VA system who would seek to volunteer and practice in the western part of North Carolina, who do not have a supervising physician in North Carolina who's licensed in North Carolina. It also seeks to address the inactive or volunteer or retired providers, nurse practitioners, who still maintain their national certification, so they haven't been out of practice greater than 5 years, who would wish to practice in this area and support Western North Carolina. Currently, under our rules, the process is that they apply for registration, NPs apply for registration and are granted registration, and they also have to apply for an approval to practice. Under Rule 804, when they apply to practice with the North Carolina Board, The board goes ahead and requests as part of the rules, a copy of the collaborative agreement with the primary supervising physician listed. And at that point, the medical board works with the Board of Nursing to verify the licensure status of the physician as well. This is a barrier to providing additional assistance as ordered under Executive Order 318 for those individuals who are currently not licensed in North Carolina, or for the cohorts if their supervising physician is unwilling to extend their collaborative practice agreement to supervise in this area. At this point, we don't have the ability to approve individuals to practice in North Carolina without a supervising physician. I do recognize that in our joint rules, it's BON Rule 0814, practicing during a disaster, which is attached to your packet, that there is a 15-day grace period, if you will, but this doesn't address the needs of those nurse practitioners coming from other territories, or those who are inactive or seeking to volunteer, or those who have retired. So the first ask is to waive the supervised physician requirement solely for that area and in that limited period of time. As we've seen, I'm sure from all of the media reports, from the governor's order, this is a declared state of emergency that doesn't have a known expiration. At this point, the request is limited to the end of the year. That is based upon reports that the Board of Nursing has received from individuals working in the western part of the state that talk about the needs that they are facing now. This takes into account that it is a limited ask, and a very big ask, but one that we believe is needed to provide the workforce for that area. And that's our job in protecting the public and supporting the public. In addition, providing relief for those practitioners who are already there to get additional workforce in that part of the state as quickly and expeditiously as possible, while also still containing key points of regulation so that we're making sure we get qualified people there. These restrictions, again, I ask in addition for waiving the supervising physician requirement only for those in that area. I'm also asking for the same relaxations for those individuals who currently practice in that area under supervising physician, relaxing those QI requirements, the meetings, the collaborative practice agreement being housed at the same site. And the reason for that is, again, those are consistent with the waivers through COVID. It also gives more flexibility to the individuals practicing in that area. Unlike COVID, this is a little different. This situation is the result of a natural disaster and focused on the needs of the community in that area, as opposed to a national healthcare crisis, which limited everyone's resources nationally. In this situation, we are concentrated on the resources needed to provide assistance and support to that community in Western North Carolina. So we do have the benefit and advantage of bringing in individuals who currently don't practice in this state to support and assist the community. That's the overall gist of the ask and for the committee's consideration. As I mentioned earlier, I was able to speak with Marcus and explain some of these barriers, and I believe he's going to present some of the things based on our conversation that he would be in support of, and some modifications that he would also like the committee to consider. So I am available if there are any questions, but I also want to invite Marcus to speak on the recommendations that he is proposing as well.
Thanks, Meredith. Marcus, would you like to make some comments?
Thank you, Dr. Johnson. I will make a few comments. When Meredith and I discussed this, one barrier was that when an out-of-state nurse practitioner applied for approval to practice, she was unable to identify, or he was unable to identify, a supervising physician because they're not here yet. You know, they haven't been on the ground. They don't know where they're going to be plugged in. So it was agreed that as part of the application process, that a limited emergency approval could be granted to a nurse practitioner, an out-of-state nurse practitioner, without first identifying a supervising physician. I think there's agreement there. Under the current rule, which Meredith cited, a nurse practitioner can practice under supervision. I guess there will be an interpretation by the staff and the two boards that the 15-day it will be seen as a grace period, that we will allow nurse practitioners with emergency approvals to practice for 15 days. That 15 days will allow them to integrate into an organized response. And hopefully that organized response, as part of the team response, there will be physicians, there will be doctors as part of that team response, and they will supervise whatever APPs are on the ground there. During that 15 days, the person with the emergency approval will provide a practice site. What are they doing? Where are they doing it? An address and phone number, how we can contact them, email, of course. A description of the practice, including whether the practice is part of an organized response, the name of their supervising physician, and if they're unable to obtain a supervising physician, an explanation as to why not. Depending on that explanation, the staff can bring that to the boards, the joint subcommittee, and then to the two boards about why nurse practitioners are unable to obtain supervision. This provides, the same would apply for in-state NPs who show up, volunteer, get plugged into an organized response, and if they're, for one reason or other, unable to find a supervising physician, they could explain why. Hopefully they'll, like I said, part of the organized response would be that doctors are part of that team and they will be willing to supervise. If not, then we'll have data. And based on that data, we'll be able to make determinations about what exactly are the obstacles. And then if those obstacles cannot be overcome, the boards can take additional actions. So the discussion we had centered around three general ideas. One, allow nurse practitioners to come into the state, get approval without first identifying a supervising physician. Two, allows them to begin volunteering, begin practice. And then three, within 15 days, they're either integrated into an organized response and they have supervision, or they explain to us what they're doing and why they can't get supervision. And then based on that data, we can make further determinations whether that practice needs to be extended, or do we just need to, revisit the whole issue about should there be some supervision at all during the course of the disaster relief. So that was the discussion we had, and I believe there's some general agreement that if there's not the big ask, then we can do at least this modified ask. And I'm happy to answer any questions the committee may have. Thank you, Dr. Johnson.
Thank you. Any questions from the committee or concerns, comments, discussion? Yes, Dr. Steele.
Hey, thank you so much. I just wanted to underscore the importance of this conversation and what we're talking about. I'm a community member of the North Carolina Board of Nursing, and so I bring a perspective that's not necessarily rooted in maybe what the practice or protocol was for this type of emergency response back during COVID and other natural disasters or other things. But I just wanted to say I was on the ground yesterday in Asheville, in Candler, and some of the areas that were devastated. And it was just difficult getting cell phone service, let alone having the internet and other access. I saw nurses walking from, hospitals into the community, trying to give people access to healthcare. We're getting reports of just different communicable diseases that are occurring in larger populated areas of Asheville and the surrounding areas. So it's really unfortunate what's happening, but I just want to make sure that some of the things that we're considering are not things that could end up being a barrier, but also make sure we provide the right access and the right supervision that any APRN needs and deserves, but also making it at least a little bit easier for them to get to the people without having the barrier of paperwork or being inundated by things that might prevent them from getting into the community and doing what they need to do to assist some of the agencies and hospitals and clinics on the ground. It is bad. It is really, really bad. And I didn't really process how bad it was until I got there. And seeing people just kind of walking around, wandering aimlessly was not something I expected to see. I expected it, I guess, but I didn't really know what we were going to encounter. So I just wanted to provide that commentary. I think we're kind of all aligned, but any barriers we can reduce will be tremendously appreciated by those on the ground.
Thank you, Dr. Steele, for sharing your observations based upon what we've been presented. Did you perceive any barriers to what you experience out there with the changes that were mentioned?
The only thing that concerned me was the tight timelines of having, identified a particular person or agency or group to supervise, because people are coming in and they're literally just driving there to Western North Carolina, getting out of their cars and figuring out how they can assist and how they can help. So if that particular timeline or time frame or 15 days or X amount of days to do this thing and get their connectivity up and running, that's the only thing I want to make sure we don't make more of a barrier than it has to be. So maybe, I'm not saying 30 days because I don't know what the protocol is and I don't know what's reasonable, but I am asking for consideration around those types of things.
Thank you. Mr. Pinero?
Thank you, Dr. Johnson. So I like to have things explained to me at a very, very basic level. So say I'm a nurse practitioner from California. I want to come down and help out. Do I need to have a quote unquote a job or a place where I'm working at before he or she is granted the ability to practice? Or can they just come in and say, I'm going to get there, and then when I get there, I'll just find a job? What's the mechanism for that?
Ms.
If I-
Parrish?
If I may speak, thank you, Mr. Pinero. Under our current rules, so outside of the practicing and during a disaster, if they're coming in from California, they're approved in California, because there isn't an APRN compact, they do have to apply for an approval to practice in North Carolina. And in order to apply and get granted one, they have to have a named supervising physician that is also vetted by the Board of Medicine. Under the disaster rule that's been cited, it's 14, which Marcus has referenced, 814 and the Board of Nursing Administrative Code, they have that 15-day grace period, but they're still required at the end of that 15 days to come up with a supervising physician and name the practice site and have a collaborative agreement in place.
Okay. And that's for any state, actually.
Yes, sir.
Okay. Thank you.
Dr. Thomas?
Thank you, Madam Chair. I do have a question regarding, and maybe it was something I didn't understand, the 15 days. To me, that seems like it may perhaps be a barrier. As a nurse practitioner, when I start work outside the VA, I speak from experience. It's very challenging trying to locate a collaborating physician in the state of North Carolina, let alone if someone were to travel from another state to North Carolina, it would be more challenging. So I'm just trying to, maybe Marcus can explain the 15-day, because it seems like a lot of paperwork and a lot of barriers, because there is a need for reduction in the regulatory burden of, nurse practitioners in the western part of North Carolina. And like Dr. Steele says, she brings a perspective from a public member with the North Carolina Board of Nursing. I bring the perspective of a VA nurse practitioner. So this practice is not new to me or my nurse practitioners. clinical nurse specialists or certified nurse midwives in the VA. I, along with the VA APRN colleagues, with the exception of CRNAs, we're living testimonies attesting to the fact that removing these barriers altogether can be beneficial for the overall health and well-being for those affected in this area. And like Dr. Steele said, it's a need, and removing any barriers that we can, I think, is our due diligence to do so as a committee. I think, to me, just removing any barriers we can would be favorable. And it would be a huge disservice to the individuals already impacted by the hurricane in that area if we have more barriers there.
Any other discussion?
Dr. Johnson, if I could just address Dr. Thomas's question about where does 15 days come from? If you look on the last page of your packet, and it's a draft waiver that asks to waive some of those provisions which are highlighted, but the current rule is provided for you all in that packet, and it's 0814. Again, the medical board has the own corresponding ones, but it talks about how the nurse practitioner who already has a current approval has to notify the Board of Nursing in writing with the names, practice locations, numbers, and the primary supervisions within 15 days after they've started performing a medical act. So after they've started volunteering during the disaster. It still requires them to get a supervising physician and have those details figured out within the 15 days, which is part of what we're seeking, or part of what the ask to the committee to consider is seeking waiving the requirement for the supervising physician so they're not limited by the 15 days, in addition to finding someone there to supervise their practice.
Correct. Thank you, Ms. Paris. But I think I was just trying to understand Marcus's comment about, he was saying, and maybe it was just me misunderstanding the other paperwork that he felt that was necessary. And Marcus, maybe you could explain more what you were speaking of, and maybe it's just me not understanding what you were saying.
Yes, Dr. Thomas. And also to pick up on Dr. Steele's comment about people just showing up in Nashville. The medical board staff has been in communication with DHHS Emergency Management. I have not had those personal communications, but I've spoken with others who've had. There's certainly, from what I understand, a need for coordination, a need for organization of the volunteer response. A lot of roads are impassable. It's kind of hard to get around there. As Dr. Steele said, cell phone access is not great. So it's kind of good to know where people are and where they're going and how we can track them and make sure that they're going someplace and get there safely because of just the conditions of the roads. As Meredith said, the 15 days is part of the rule. So if folks are coming into the state and volunteering, it is the hope that they get plugged into an organized and integrated response. So people know where they are, what they're doing, and that they're able to get there safely. As part of the current rule says you have to tell us your supervising physician within 15 days. We're not saying that the 15 days is like 15 days, you got to tell us your stop. Is that 15 days, you tell us what it is you're doing, where you're doing it at, do you have a supervising physician, and if not, why not? That gives us the ability to evaluate what people are doing, what's happening on the ground, and make better decisions. 15 days is what's in the rule. As Dr. Steele said, could that be 21 days? Could that be 30 days? I'll defer to the wisdom of the committee. But whatever the committee recommends, we'll take that to the two boards. It was a way of tracking people. One, we removed the need to identify a supervising physician at the beginning, get people approved. They show up, they get plugged into a system, and then they tell us where they are and what they're doing. Including as that is, do they have supervision? If not, why not? So I hope that answers your question, Dr. Thomas. But the 15 days comes from the rule. If the committee wants to modify that, that's certainly worthy of discussion. Thank you.
Any further discussion? I'm looking for hands. I'm trying to see if hands are up.
Dr. Ingram has her hand up. Dr. Johnson.
Dr. Ingram?
Thank you. So my question about the 15 days, if we leave the 15 days in place, then, and with the proposal that Marcus shared, afterwards, what happens when we are waiting for the nurse practitioner to be evaluated? Are they pulled from care? And if they are, then what's happening with those who are actually needing this care? With this day 16, are they evaluated, or is it day 20, 30? Just trying to understand.
Mr. Jemison?
I would believe, one, that's a good question. That's a great question. If they don't respond to us in 15 days, then I think there should be some communication to the NP that they need to respond or the emergency approval will expire. I would probably give them a chance, have either the nursing board or medical board staff reach out to them and say, hey, we need to know where you are, what you're doing. Please get up with us. If that goes on for a certain period of time, say 3 or 5 days, then there would be further communication that the approval is expires. If they do come back and they say they're without a supervising physician, the staff will evaluate the circumstances. I would suggest allowing the presidents of each board to make a determination whether to extend that approval given the circumstances. But that's a good question. What happens after the 15 days? I think hopefully most people will communicate with us. And if not, we'll try to reach out to them. We'll try to figure out what happens. And once we get information, we'll evaluate it. I don't want to suggest or propose some sort of rigid or inflexible standard. I want there to be as much flexibility and consideration as possible.
And if I
Yes, go
may,
ahead, Dr. Ingram.
thank you. I appreciate that flexibility. But an additional concern is, like Dr. Steele mentioned, and also like what we've seen on the media, their ability or possibly their inability due to the limitations with technology. And so with that, that brings yet, still somewhat of the same concern within that time frame. What if they are not able to connect or reach out, and then the committee is unable to evaluate within a time frame that is conducive to the needs of the communities involved? And so that's my concern, for the people, those in need, being able to receive this much needed care and not having the limitations that would disturb that.
Mr. Jemison?
Those are great points, and some of the discussions that has happened in the last 24 hours. And again, these are discussions that I'm not always firsthand in, but the notion, one of the hypotheticals is having a person out there on their own without anybody knowing where they are. That is considered a possible public health safety risk as well. People show in from another state, they start doing something. We don't know who they are. We don't know, well, we know who they are, but we don't know where they are. We don't know what they're doing. Are they part of an integrated, organized response, or are they just out there writing prescriptions? So we're trying to balance both, making sure we know where people are, what they're doing, and also, like you said, and everyone's been saying, make sure we can increase the numbers of people who are helping out. We're trying to thread that needle.
I think Ms. Parrish was next, and then Dr. Ingram. Meredith, you're muted.
I put my hand down but didn't unmute myself. Thank you. I want to address what's before the committee. So there's like a couple branches going on. So the first ask is to consider waiving the supervising physician requirement only in that area after they've been approved to practice through December 31st. They still have to apply to practice and be vetted through the boards, but they don't have to list and name a supervising physician. So that's the big ask. And to reduce the requirements of a QI meetings and collaborative practice agreement, which is consistent with 0814, practicing during a national or during a disaster or state of emergency. What Marcus has proposed and talks to is, I believe, and if I'm misspeaking, Marcus, please correct me, that there is an agreement that we could do a temporary emergency approval would be appropriate. Where we diverge is 15 days going to be a significant amount of time to reasonably expect the nurse practitioner coming from another state or someone who has been inactive to find a supervising physician willing to supervise their efforts in that area, which is what arguably is the barrier that they're facing right now. It's not that there won't be a way to track who's coming into the state or vet them. It is, though, seeking to remove the barrier of an additional finding a supervising physician, finding someone willing to work with them in that area. And so that is part of the ask and why that's there.
Dr. Ingram, one second. So Meredith, when you laid that out, I have two comments. Also, NPs in the state who go and work there may also fall under this, because if their current supervising physician does not want to continue to supervise them when they're in Asheville or in the western part of the state, they would fall under this as well, correct?
Yes. Yes, they would, Dr. Johnson, and we've been keeping track of the calls that we've been getting from MPs and others. We have had one individual wanting to go from Durham to the western part of the state who their supervising physician does not wish to extend their collaborative practice agreement to that area. And again, I think there's concerns on both sides. It's, up to them to decide personally, but that's a barrier for that nurse practitioner to go practice in the western part of the state.
And before I go to Dr. Ingram, you outline exactly what we need to consider. Would it be best for us to take those separately and go ahead and have a motion to accept them regarding coming out of state, regarding the need for supervision, and then just divide them into the three categories?
I think that the committee certainly could do that. And I do want to be clear that this committee is putting forth a recommendation to be considered by both boards. So you could take it as, is the committee in agreement, or is there a motion to permit an emergency approval such that they can be approved without having a supervising physician and collaborative practice agreement in place, provided they meet all of the other requirements of the rules. So that would be part one.
Okay.
Yes, thank you. I just, I think Meredith spoke to it. I thought I heard her include that with the comment that Marcus shared about, nurses just coming in and we not know where they are, but there is a process already in place. And so that chaos with this process will not be as, possibly thought. So thank you, Meredith.
Okay. Any other comments or discussion? Dr. Patel?
Yes, thanks. I'm sorry, I just want to make sure I ask a sort of a fundamental question. So if a nurse practitioner comes into the state, either from outside of this state or from another part of the state, I think Durham was the example that was given, and we sort of made a provision temporarily that they don't have to notify us who the supervising physician is. How does, because of the various barriers, there's not internet service, or there's all the things that have been mentioned thus far. I would assume that there are physicians around in that area as well is there a possibility, for example, of getting some of the existing physicians in the western part of the state to sort of take on, no one can force them to obviously accept and take on a supervisory role. And I think the other question I had was if we don't really know where they are per se, you said we would know because there's sort of a process in place. So we know that they are in a certain location seeing patients, but who would that nurse practitioner go to if there was like a clinical situation that was kind of out of their wheelhouse or out of their scope of practice and they didn't know how to manage that situation? If there's no cell service, no electricity, there's no internet, and we're allowing an out-of-state nurse practitioner, for example, to come into the state unsupervised, seeing patients in the western part of our state, and they run into an issue that they can't manage. What do? They don't even have a supervisor at that point.
Wouldn't they maybe refer to the local hospital? And I'm just shooting in the dark. Is that not what they would do in general? Like refer to whomever's like the largest medical practice in the area, which in this case might be Mission in Asheville. I'm not sure in Boone or some of the other western parts. But that's just, I'm just asking, is that not what they would normally do if they're not able to reach their supervising physician?
I guess I'm sorry, may I speak?
Yes, please.
I guess as I thought about it a little further, it's like I don't know, if the hospital systems are feeling overwhelmed at this point with influx of a lot of patients coming in. So I think a knee-jerk reflex to say, I don't know how to manage this, I'm going to punt it over to the hospital system, may end up overburdening a hospital system which is already stretched thin given everything that's going on. So that's also a concern of mine. I think it's great that there's some guardrails put in place to say, hey, I know where this nurse practitioner is and generally what she is doing, but to not really, in some ways, we don't really know on an everyday basis what she's doing or he's doing. I mean, we might know that she's in Asheville, seeing these patients, but there's no sort of, I guess I'm just a little concerned that, I guess, that someone might be doing something that they shouldn't do, not with malintent, but just because we don't really have sort of a checks and balances in place. I hope that makes sense.
Dr. Ingram? I'm sorry, go ahead, Dr. Skill.
I was going to say, so on that note, is it possible to consider, or does it exist already, an on-call system for attending physicians who are able to answer those types of questions or respond to those types of in the field needs at the ready? And I don't know if this exists, but as a community member, I know that I can call the nursing hotline in my local area in Cabarrus County, and I can reach a nurse and she can help me triage what's going on with my children, my family members, before helping me make a decision as to whether or not I'm going to bring them to the hospital or to the ER. Does that exist for nurse practitioners to be able to call attending physicians or other physicians who can answer those types of questions similarly to how their supervising physician would answer? That's a potential guardrail that we can put in place so that, again, this is an emergency. It's not ideal, it's not likely, but it's something that can help mitigate the concerns on the ground temporarily.
Dr. Ingram?
And so I certainly respect your concern, Dr. Rayo Patel. Hopefully I said your name correctly. But with that, the other piece of that is if the nurse practitioner is not there, then what happens to that patient who needs care? Then nobody's there and they can't get to the hospital. So having someone there to hopefully be able to manage care, and if there is an extreme emergency, then that person likely would have been referred to a hospital system that is more than likely already overwhelmed. And so again, the other piece of that is to have that person there, and that patient would likely have to go to the hospital anyway. So better to have the services there than to not have anything at all is my point for the already overwhelmed system.
All right, Dr. Thomas?
I think, like, for me personally, I don't have a supervising physician. So just being professional, I would know to go to the subject matter expert. There are others, just as physicians would. They're not supervised, but they do have someone they could call on to escalate the problem in the event that they need assistance.
So, Ms. Parrish, as I mentioned before, do we want to go ahead and move towards a resolution?
I certainly think you could ask for a motion from one of the committee members to do that.
Do I have a motion from the committee members or an amendment to a motion? Amendment to the recommendation.
So I think, Dr. Johnson, because there's been a lot of talk about what the actual recommendation is.
Do you want to repeat it?
I would ask if, and we'll start. The recommendation would be to waive the supervision requirement for a supervising physician only during the state of the emergency through December 31st, 2024 for nurse practitioners approved to practice in those counties only.
This is
That'd be
LaDonna.
Part one.
For part one. Are we doing it separately? We're gonna vote on this one and then
I think
the
we
next
should.
one. Okay, so I'm so moved for part one.
Do I have a second?
This is Raquel Ingram, my second.
Yep. The motion carries, it passes. The recommendation does from us, the joint subcommittee, to the two boards regarding to waive the requirement for supervision.
Do we need to call for a vote?
Oh, I'm sorry.
Yeah, Dr.
That's
Johnson, you got
right.
to call for a vote.
That's right. Okay. Call for a vote. Moving too fast. All right, we'll call for a vote by roll call. Dr. LaDonna Thomas,
Approve.
Dr. Amy Still,
Approved.
Dr. Raquel Ingram,
Approve.
Dr. Ro Patel.
Dr. Johnson, can I just get clarification? So we are voting right now just like at a high level to approve the removal of supervision. Is that correct? Like initially when a nurse practitioner, whether they're in state or out of state?
Or inactive.
Or
Yes.
inactive. Okay, so just to say, yes, this is going to move forward. Is that what we're voting on? I just want to make sure I'm
Yes,
like, okay, that's fine.
just
Yes.
that part.
Okay, thank you.
So yay or nay?
Yes, yay.
Mr. Pinero,
I'm cool with it.
and I also approve, Dr. Sharona Johnson. So the motion carries. We'll make that recommendation to the two boards. Ms. Meredith, if you can help us with the second part?
I think, as I understood the motion, so let's be clear, the motion was to waive the supervision requirements for MPs in that area during the state of emergency through December 31st. And as the committee has voted to approve that motion, there doesn't need to be a further motion because that takes it out of that addresses the disaster practice and the other concerns that have been discussed.
Well, I think there was still some discussion about the 15 days.
I think if you waive, if you look at 0814, if you don't have to have a supervising physician to be approved to practice for that time period, you don't need to discuss the 15 days. I think Marcus might have a different take on it.
Mr. Jemison?
Yeah, I think there may have been some confusion whether the vote was to remove having to designate a supervising physician in order to be approved. And not knowing that the motion was for that a nurse practitioner can come into the state and practice without any supervision and without notifying the boards, where her practice is or his practice is, what they're doing, all that for the next 2.5 months. If I'm, misunderstood, or I think there might be some confusion on that, then I'll step aside. Having said that, however, because this is a recommendation, even if the committee wants to recommend approval without any supervision or notification of the boards of where they're at for the entire duration of the disaster or December 31st, you can certainly make that recommendation, but I would also request, and I know how that somehow moots out the second request, that you do it for just 15 days with this notification requirement or for a little bit longer. But if okay with you, Dr. Johnson, as the chair, I would ask the committee that in the event the full boards want to do something different, they want to do a hybrid of anything different, would the second proposal, would the second modification also be a recommendation to the two boards for something to consider? So I think you can do both. Basically, to make it very simple, I think you can vote on both recommendations and send both recommendations forward to the two boards to consider. Thank you.
Ms. Parrish?
I defer to you, Madam Chair. I think perhaps I thought the motion was clear, but I guess it doesn't matter what I think. I think it matters what the committee's understanding of the motion was. So I perhaps maybe clarify.
Okay. Dr. Tillman, was your hand up?
Yes, I think it was very clear, the vote, and I don't think anyone was misled. So I think you should go with the vote. I think with other people getting in and trying to persuade committee members, it's up to the committee to decide what the right thing to do is in this decision.
Okay. I can't see if anybody else's hand is up. Oh, Dr. Patel.
Yes, I'm sorry. So I think I need some clarification about what we decided about 15 days or not 15 days, because I want to make sure that I understand. I'm sorry.
Can you read is it possible to read the piece that we are all looking at in Dropbox or in the documents? Can we the part for her to, or for all of us to have clarity?
Ms. Meredith, do you want to read it?
Yes.
Okay.
The motion is, it was presented from staff's recommendation was to waive the supervising physician requirements for those nurse practitioners practicing in the western part of the county during the state of the emergency through December 31st or during the state of emergency. So waiving it all together.
So that motion actually passed for recommendation, but I would like to say, I think there probably was some clarification needed, because I think Dr. Rapatel, when she asked for clarification, did not understand that it meant waiving supervision without the inclusion of the 15 days. But I do agree with Marcus that this is a recommendation to the two boards. And so the boards can accept the recommendation or choose not to. Is that my understanding, Ms. Parrish?
Yes, the recommendation have to be presented to both boards to vote.
All right. So I would say let it be presented to both boards, and then the boards can vote or make amendments to the recommendations as needed. Is there any further discussion or questions before we adjourn the meeting?
So let me just clarify, because according to Robert's rules, we have already voted on the matter that was presented before us. And so because we have voted and it's gone down in the minutes, if we were to change that for any reason, then we'd have to have another motion presented to make an amendment, a change, or anything like that. And then it would have to have a second and then pass. So my question is, what are we doing?
It's a recommendation from our committee. So we make a recommendation to the board. So it has to go to the Board of Nursing and the Medicine Board before it's passed.
Okay, so you're not recommending to rescind or do anything different with the vote that we just completed?
No, it goes to the board as it is.
Okay, thank you.
But you should understand that the boards can change it or choose not to vote on it.
Yes, I
To pass.
understand.
Okay. All right, any other further discussion? Okay. The next annual meeting of the Joint Subcommittee will take place on November 19th, 2024 at 3:30 on Microsoft Teams. Thank you for your attendance of this emergency call meeting of the Joint Subcommittee. And I do ask for a motion to adjourn the meeting.
Madonna, so
Madam
moved.
Chair, I will make a motion, but I wanted to just confirm that it's at 2:30 rather than the 3:30 for the minutes.
For the next meeting on November 19th,
Yes.
it'll be at 3:30, right?
Yes, the midwifery joint committee is at 2:30 on the
I'm
19th.
sorry. You are
All right.
correct. Okay,
Um,
I'm looking at two different things. Okay, thank you. My apologies.
That's okay. All right, so we had a second, and all in favor say yes or a or yay. Hi. All right, thank you. Thank you.
Yes.
This concludes today's emergency call meeting of the Joint Subcommittee. I believe the Midwifery Committee will be meeting next. Thank you.
And it is in a different room, Dr. Johnson and members of the
Okay.
committee. It's a different meeting.
Thank you.